Hello, everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me today. I'm very honored to be joined by these specialists who are going to talk today about the topic of osteoporosis. Joining me on the panel is Dr. Ben Elder from the Mayo Clinic, Dr. Jason Savage from the Cleveland Clinic, and Dr. Paul Anderson from the University of Wisconsin. We're here at the Lumbar Spine Research Society, where Dr. Savage has just been named the president of this remarkable organization. And so I'm going to start off our conversation by asking Dr. Savage to talk to us about why doctors and spine surgeons in particular who treat patients with lumbar spine challenges are talking about osteoporosis. So tell us, Dr. Savage, why is osteoporosis a topic here for the lumbar spine doctors?
Yeah, I think that's a great question. You could see throughout the entire meeting, starting with the instructional course lecture yesterday, a session today, tomorrow, it's a huge focus for our society right now, because I think it's really important for patients to understand kind of how important bone health is if you have spine issues. And from our standpoint, it's one of the things that we need to focus on and optimize prior to surgery to try to minimize complications, to optimize outcomes, and really to try to get people through their spine surgery as best we can.
That's great. And Dr. Elder, you are joining us from the Mayo Clinic, where you run a bone lab and you treat patients as a neurosurgeon, and yet you are very concerned about bone health. How does this affect your practice, and how do you, as a neurosurgeon treating spine patients, see the need for osteoporosis education?
Right. So osteoporosis and bone health is critical in my daily life as a spine surgeon. And so a lot of patients need instrumentation to help fix the problem with their spine. So that often means screws and rods. And if you think about putting screws into drywall or into a stud, there's a big difference. And so patients who have very poor bone, even the paper on drywall, we don't really have surgical options we can use to treat them. The patients who develop fractures can also have problems where they can get weakness from the fracture of the pieces of bone pushing on their spinal cord, or pain and weakness from pushing on the nerves as well.
And Dr. Anderson, you have been studying osteoporosis for spine patients for many, many years. I believe you may have more scientific papers published on this topic than anybody. And so it's just a real honor to have you joining us today. And I might also mention that Dr. Anderson is one of the co-chairs of our Spine and Bone Health Task Force. Dr. Anderson, tell us what you're seeing now with more spine surgeons tackling this topic, and why it's different now than it has been in previous years.
Well, I think through the experience of seeing a lot of complications from elective surgery that are really related to the underlying bone disease we call osteoporosis, surgeons have woken up to the fact that we want to try to avoid these because they're very harmful to the patients and very costly. And so we want to diagnose them and treat them before surgery. This is very similar to the many conditions that we now optimize prior to surgery. For instance, blood sugar control is now optimized, cardiac risk is assessed, and a variety of other things that happen behind the scenes to a patient, where the surgeons have protocols to evaluate and get all these medical conditions optimized so that we have the best chance of a successful outcome. Bone health is the newest one added to that. Fortunately, we have effective treatments that are available to patients who need this type of optimization. So we've made a lot of progress, and we can help patients now.
And I think one of the things that all of our doctors are mentioning today is that our bones are a living, breathing organ that need to be paid attention to. And that's something that a lot of people don't think about. So I'm going to ask all of our doctors today to comment on this notion that people need to know their bones just like you would know your cardiac health, you need to know your bone health. And what does that mean? So much of what we're trying to do is to empower you to ask your doctor about these questions about your bone health. So I'm going to toss it down to you, Paul, to start, and we'll just come down the line here and comment on that.
Yeah, Dr. Roy, I agree that patients need to know their bones. One thing you need to understand is that bone is a living organ, and it's constantly being broken down and replaced. We reach maximum bone strength in our 20s. And then once after 20s, we begin to lose bone strength approximately 1% per year until age 50 in women, when they typically are reaching menopause. And when estrogen decreases in women, they start to lose bone faster, usually about 2%. And this can lower your bone strength to the point where you are going to sustain what we call fragility fractures. In other words, a fracture with a very minimal mechanism. So understanding the physiology throughout life of bone is really important, because ideally what you'd like to do is reach maximum bone strength at the highest level possible. But you have to do that in your teenage and young adult years. Unfortunately, once that horse is out of the barn, we have a difficult time fixing it.
Right. Dr. Savage.
Yeah, I think one of the most shocking things, too, is how common this diagnosis is. I think historically people thought that this was a disease of postmenopausal women. Totally not true. I think the global prevalence right now is almost 20%, so 60 million people in the United States have a diagnosis of osteoporosis. For what we do for a living in spine surgery, it's an alarmingly high rate of, the percentage of patients that come to us who have a diagnosis of osteoporosis and they don't even know about it. Some studies show that up to 50% of women over the age of 60 who have spine surgery have a diagnosis of osteoporosis. And it's also a disease of men, 30% of men over the age of 75, and up to 20% of spine surgery patients, men, have a diagnosis of osteoporosis. So I think the recognition part is something that we're really starting to kind of recognize, and how important it is to kind of get this diagnosis, to understand it, and then more importantly, to get it treated.
Right.
I think, as Dr. Anderson had described, we achieve our peak bone mass in our 20s, and usually by the late 20s and 30, we've gotten as high as we can get. And so it's critical to pay attention when you're younger, and also pay attention to your kids to make sure they're getting adequate nutrition, calcium and vitamin D, things like milk and dairy products, or if not, at least taking supplements to maximize their intake. And then also any sort of weight-bearing activity. So it's important that kids get outside and are maintain their activity. So a sedentary lifestyle, and then also in your 20s using alcohol or starting to smoke can have significant harmful effects on your bone. And that's especially important when you're still developing and increasing your bone mass, let alone afterwards when it decreases at a faster rate.
And we think about the bones as a static organ, like it's like a coat hanger in your body and it's holding your body up, but that's not true at all. And Dr. Elder, you have this great analogy. Can you share that?
Yeah, so your bone is constantly being remodeled. So there's certain cells that break down the bone, and then other cells that come in and make new bone. So it's constantly being replaced. And this happens where your entire skeleton is replaced about every 10 years. So you can think of it in some ways like the shingles on the roof on your house. Typically, we get those replaced all in one go at 20 or 30 years. But in this case, it would be like coming in and every year you're replacing a couple of the shingles at a time. So by that 10-year time point, you have a brand new roof.
We're talking about the fact that our bones are a living, breathing organism. We're talking about the fact that our bones are a living, breathing organ that changes dynamically over time and over the course of our lifetime. Dr. Savage, you mentioned that you see increasing numbers of women and men that are coming into your clinic with osteoporosis. How do you talk with your patients about this condition when they come in to see you for a spine problem, and now they find out they have a bone problem?
I think we're starting to kind of understand more and learn more about this kind of disease process, particularly in the spine surgery population. I think it's really important that we kind of initiate the evaluation. There's actually some pretty good data to support that if kind of orthopedic surgeons or spine surgeons, neurosurgeons start that process, start the discussion. It's more likely to actually be done than just kind of a referral back to a primary care physician. I think it's on all of us, though, as healthcare providers to kind of, increase the awareness about how important this is and the diagnosis. From our standpoint, the conversation is really we need to optimize your bone strength prior to surgery to minimize the risks of the surgery itself and then to minimize the risk of mechanical complications or the screws loosening or fractures after surgery, all things that tend to just lead to kind of the spiraling effect, that can unfortunately lead to poor outcomes.
And Dr. Savage, can you talk with us about how it works in your practice? So patients come in, they find out they have osteoporosis, and then they need to do something about that before they have their spine surgery.
Yeah, great question. And we're lucky at the Cleveland Clinic, just at the institutions like the surgeons next to me here, we have a pretty robust kind of bone health program. So I typically just start the conversation with patients, ask them if they've had a recent bone mineral density test. Oftentimes we can actually use a CT scan too to get a general sense of what the bone health is like. If there's any suspicion of an underlying bone health problem, then we're referring those patients to our bone health provider, which is run by a rheumatologist at the Cleveland Clinic, who really kind of helps spearhead the evaluation, the comprehensive evaluation, and then the treatment of the underlying problem if it's diagnosed.
And thank you for sharing that. And I think what's interesting then is in that next step, as Dr. Savage is saying, he is sending the patients then to a rheumatologist or a bone doctor. Now that bone treatment has to start before the surgery can happen. So Dr. Anderson, you have an incredible analogy to share with us about why it takes time for the bone to become strong. And that takes a period of time because the bones are a living, breathing organ. And we've got to build up the bone, and that doesn't just happen in a week or two. That takes some time. So can you talk with us about that?
Yeah, so our bones, like we've mentioned, are constantly undergoing replacement or remodeling. And that is done by two types of cells in our bones. We have cells that break down the bone, and they are called osteoclasts. And then we have bones or cells that form bones. We call those osteoblasts. And they work together and a little bit in competition. And unfortunately, the aging process, the cells breaking down bones are winning the case. That's why we lose bone mass. The analogy we like to use in Wisconsin is that in the winter, these bone cells that break down bone are kind of like the trucks driving over our roads in the frozen roads and creating potholes. And so these cells that eat up bone are like the things that create potholes. Mm-hmm. And then in the spring, we call in the construction crew with concrete, and those are the bone-forming cells, and they fill in the holes. Now, they never get it perfect, and it's not quite always level. And so that same thing happens in the bone, and that's why our bones change with age. Mm-hmm. Now, the nice thing is that the medications that we're going to talk about, they work on both sides of this balance equation. That is, we have medications that inhibit the bone cells that are breaking down bone, and we also have medications that stimulate those bone-forming cells, depending on what the individual patient needs are.
Yeah, that's such a great analogy to visually think about. Craters are formed and then they're filled back in, and that process is happening dynamically all the time. And I think one thing that people don't realize is that your bones serve as a bank of calcium for your body. So our incredible bodies use calcium for many cellular functions. And where does that calcium come from? Well, it comes from your diet, right? And if you don't get enough calcium in your diet, then it's going to extract it from the bones. And so it's such a miracle the way that our bodies work, that the osteoclasts and osteoblasts are working that way to help provide the body what it needs. So So can we talk a little bit about that, Dr. Elder? You study bone a lot. Talk to us about bone, the calcium bank in our bodies.
Yeah, I mean, so calcium is the critical building block of bone and helps with the mineralization. Your body, again, with all this remodeling, is constantly taking calcium as well as some of the phosphate and reorganizing it. And so you need to keep replacing that in your diet. And this can change in certain diseases. So if your parathyroid gland has problems, sometimes it breaks. It's too active, and you'll start breaking down your bone because your body is trying to get the calcium out.
Right. And Dr. Savage, do patients ask you what kind of calcium they should take? Is that something that comes up with your patients?
It's a great question. It's rare that they ask that question, but we kind of basically ask it to them, I think, And the other thing that we've learned a lot about probably over the last 10 years is the importance of vitamin D and the prevalence of vitamin D deficiency, right. Which is actually very, very high. I could tell you anecdotally, personal story for me. When I got my first vitamin D level tested like 5 years ago, I was profoundly deficient. No clue. And so it's very, very common to be vitamin D deficient, particularly in areas like Cleveland. I don't see the sun very often.
Yeah.
But so it's really
working in an operating room all day.
but it's a very, very important kind of part of kind of the optimization process, I think, recognizing the vitamin D deficiency, replacing it. There's actually a lot of good data that's been shown now that we've looked at here at the Lumbar Spine Research Society, showing that if you're vitamin D deficient, you have an increased risk of complications after spine surgery, you have an increased risk of infection, you have an increased risk of not healing a fusion if that's the surgery you have. So that's one thing we're kind of starting to focus on as well.
That's fascinating. And as a reminder to our patients watching, vitamin D is important for calcium absorption. So when you're taking a calcium supplement, you want to have vitamin D attached to that. Right.
Completely agree. And I think in general right now, the recommendation is 2,000 units of vitamin D, D3, and about 1,200 milligrams of calcium. And I agree with you. They need to be together, because if you have one and not the other, they're really not working.
Yeah. So we've been talking about this delicate cycle in your body of maintaining calcium levels, how your bones work to enable your body to maintain calcium levels, and what happens between the osteoclast and the osteoblast cells in your body, the bone makers and the bone eaters. And that leads us into a conversation about treatment for osteoporosis, because in order to understand how the treatments work, we need to understand a little bit about how the bones work. So Dr. Anderson, you were beginning to mention some treatment approaches. Let's talk about that. So I think there's a lot of confusion amongst patients about what the treatments are. There's fear about the treatments. We want to address some of those issues.
Yeah. I think the first consideration is how do we decide which treatment is needed for an individual patient? And that has been evolving significantly, particularly in the last 4 years. We now assess whether you need osteoporosis medications based on your fracture risk of a future fracture. And there are now what we call calculators, so there are ways to measure that based on your known risk factors. Also on whether you've had fractures in the recent past, because that significantly increases your risk of another fracture. And we also include what your bone mineral density test shows. So those are the three things: your future fracture risk, your history of fractures in the past, and your bone density test. So putting all those together gives us an idea of whether you need medication and also what type of medication you would need. And so you will be put in a risk category. And in the United States, we're typically using a low risk, a high risk, and a very high risk. And examples of high risk are somebody who in the past has had a vertebral fracture or a hip fracture, or has a bone density test that suggests their osteoporosis. So we would classify that patient as high risk. Very high risk are really unfortunate patients who have had multiple fractures. They've had fractures while they've been on treatment, or they have extremely low bone density based on your density testing, or you have an extremely high predicted future fracture risk. So this last group, this very high risk, or some people might call it severe osteoporosis, those are the patients who are going to need our more powerful, and unfortunately they're more expensive drugs, so-called bone builders. Doctors may use the word anabolic, which means we're going to build the bone. So those would be the concrete construction crew filling in the potholes. Whereas the high-risk group, we might use those drugs that prevent more bone loss. And so we have ways of determining which drug might be best for you.
Dr. Savage, are you seeing in your practice as a spine surgeon treating osteoporosis patients? And how do you approach doing that for your patients?
Yeah, excuse me. Great question. I think from my practice, really, it's the initiation of kind of the evaluation part that I play a big role in.
And that's a huge step. That step right there. I mean, we sort of talked quickly over that step, but initiating the evaluation, that means thinking about, let's look at the bone quality, right? And so.
Yeah, I completely agree, and I think we've come a long way as a group of physicians, particularly spine surgeons, and kind of understanding the importance of that, understanding the prevalence of it, how common it is, and so I don't think there's a patient that I don't see that I'm thinking about. Do I need to talk to this patient about their bone health? Have they had a bone health evaluation? And then if we do the bone health evaluation and there is a diagnosis of osteoporosis, then it's really kind of helping get that person into a bone health expert specialist who can help with deciding which appropriate medication to go on.
And about what period of time does it take from identifying a spine patient with osteoporosis to them being able to come back then to have their surgery? What does that look like?
That's a great question. I think it depends on a few things. Like Dr. Anderson was just saying, I think it depends on the severity of the osteoporosis, the risk based on kind of their underlying bone health, their future fracture risk, have they had a previous fracture? And it also depends on the magnitude of the surgery, I think, that person may need based on the underlying issues that they have. I think the bigger the surgery, scoliosis, deformity correction operations, those have a really high risk of complications, high risk of failure if the bone is not strong enough. So those are patients that sometimes we have to delay even further. And typically it's about 3 to 6 months that they need to get on one of these medications to help build up the bone before we think that they're optimized for surgery.
Yeah.
Jason, why don't you discuss the case you showed me 2 days ago that you did?
Well, a case I did a few days ago was a woman, 65-year-old woman, who I had met actually a couple of years before. She had a pretty severe scoliosis, which is just a bad curvature of the spine, wasn't able to stand upright, was pretty miserable, unfortunately, and debilitated by this condition. She was found to have severe osteoporosis with a DEXA scan, our bone mineral density of -3. So it took a lot of stuff before surgery to kind of get her ready for surgery. So we sent her to our bone health specialist. We got her on one of these anabolic or bone building medications. We actually waited, I think, almost 9 months for her to be on that medication. And then we performed surgery. And so far so good. Surgery was only a few days ago. But you could tell in surgery kind of how much these medications help by the strength of the bone. Like Ben was saying too, kind of like if you're putting a screw into a really good piece of wood, that screw feels really solid. If you put that screw into a soft or wet piece of wood, it doesn't feel so solid. And these medications really help with that process.
And Dr. Savage, thank you for sharing that case. That's just a miracle that we can make these things happen for people. What will her picture look like after surgery in terms of having to stay on her osteoporosis medication?
Yeah, that's a great question. And so it's not just before surgery that's important, it's after surgery as well. And Paul could probably talk about this a little bit better than I can. But in general, these anabolic agents are given for about 2 years. So if we treat them for 6 to 9 months before surgery, they're going to be on it for 12 to 15 months after surgery.
Yeah, interesting. Dr. Elder, do you have a comment on how long patients need to stay on osteoporosis medicine?
Sure. Yeah. I mean, I think I tend to be on the very conservative side in treating patients, but I agree completely that a lot of this depends on the severity of the osteoporosis and how big of a surgery they need to have done. A lot of my practice is doing patients with spinal deformities or scoliosis, as Dr. Savage was just discussing. And some of this depends on the medication that we're using. So one of the newer medications seems to work a little bit faster. And we actually just finished a research study that's coming out shortly showing that we get improvement in the bone health of the spine a little bit faster with that one. One of the other anabolic medications that we use can actually take up to a year to see that benefit. So some patients, I'll actually treat up to 18 to 21 months before surgery. In working in our lab, we also have found some data showing that we like to use these medications after the surgery as well because they do seem to work in common with the bone graft materials that we use. It can actually secrete or deposit more bone to help with the fusion after surgery.
I would also follow up that as a kind of an added benefit through this process, not only to help out with your surgery, but if you've been diagnosed with osteoporosis, you have a significant risk of other types of fractures. For instance, even though you have a spine problem, we don't want you coming back with a broken hip or a broken wrist, something like that. So we are continuing those medications after surgery, not only to improve the outcome of the surgery, but also, just like we would any other patient, to try to prevent other fractures. So that's why it's important that once we start somebody on treatment, we have a defined treatment plan for 5, 10 years, or maybe even the rest of your life. It does not mean you're always going to be on these medicines. We typically take you on them and off them and reassess, and maybe you have to go back on them. And this occurs 5, 10 years later.
Yeah.
But we are going to have a treatment plan that is going to last a number of years. Because as I said, bone health, unlike a lot of other medical conditions, is a long-term problem. Said you recycle your skeleton every 10 years, so you got to think it like that. We're going to be given this for long periods of time.
Yeah, that's such an interesting thing for people to know, that the bone turns over. And this is what we've been talking about. The bone is a living organ that is changing, and it's dynamic and requires careful measurement and monitoring and assessment. And Dr. Anderson, can you help people understand what it means to have a diagnosis of osteoporosis? So, in other words, if you're told you have osteoporosis, do you have that for life?
You have that diagnosis for life, even if we improve your bones. Again, like I said just shortly ago, it does not mean that you will need medication for the rest of your life, but you'll have that diagnosis, and does mean you need periodic monitoring and something we now call risk assessment, because that risk assessment is what's going to define whether you need to be treated or not. So unfortunately, we can't cure you of that. We can reduce your fracture risk, and that's our treatment goal. And you should always work that out with your provider. You know, what is our goal of treatment here? Certainly from a surgeon's perspective, the goal is treatment and get your bones better so we can operate. But that is not the only treatment. The treatment is really ultimately to reduce your fracture risk. And that is going to, you can define what that is. And that should be defined with your care provider about that. Yeah. And once you reach that treatment goal, then maybe you could be on a holiday from these drugs and wait and then be reassessed. And then if you go to a higher risk category again, then you can be back on treatment.
Right. That sort of almost like triaging of where your risk is, and those 3 different categories, and where do you fall within that, and that you can move from one to the other, and that's a dynamic process for patients. So let's talk a little bit about this concept of secondary fracture prevention and why, as spine surgeons, we're talking about this. And I'll toss that back to you, Dr. Anderson, and then we'll have everyone comment on that.
Yeah. So if you're a patient who has sustained a vertebral fracture or other low energy fracture, in other words, you fell from the ground level fall, where you broke your wrist, your proximal, your humerus around your shoulder, or other bone, you likely have osteoporosis, and you need to obtain what we call secondary fracture prevention. What that includes is a bone density testing, an examination to see if there are causes for you to have more brittle bones. About half the patients will have some underlying medical conditions that some of which we can modify and improve that lead to osteoporosis. And then also get you on treatment if you reach the high risk or the very high risk category. If you are not receiving that, then we really want you to be empowered to ask your providers that I have heard that I should be evaluated for possibility being on treatment for osteoporosis. That is especially true, most importantly, in the spine, because if you have sustained a vertebral fracture after the age of 50, your risk of getting another one is 5 times those who never had a fracture. So you have an enormous risk, and they occur mostly in the first 2 years after the first one. So it's important to get the diagnosis and treatment done as soon as possible.
Dr. Savage, let's talk a little bit about vertebral fractures and why we want to prevent them and what to do if you get one.
The most important thing about the recognition and treatment of osteoporosis is the fracture prevention. There's no question. As spine surgeons, obviously, we're biased and kind of focusing on spine surgery patients and kind of the potential issues that people can have if they have spine surgery with osteoporosis, but it's really the fracture prevention that's the most important thing. We care about vertebral compression fractures because they hurt and they oftentimes cause people pain and disability. And we've all unfortunately seen a lot of patients who've had multiple vertebral compression fractures due to their underlying osteoporosis. And that's what people kind of tend to feel like they're shrinking. That's the most common reason that kind of people tend to feel like they're losing height over time throughout life is because they have issues in their spine or if they have fractures. So I think the prevention is the most important part. There are treatment options for the fractures. Fortunately, most of those fractures heal on their own. There are certain fractures that sometimes benefit from some cement augmentation. It's complicated.
It's complicated. So because treating those vertebral fractures is complicated, you want to do everything you can to prevent them, right? And I think that's what we're talking about, preventing those fractures from happening. Dr. Elder.
Yep. So I think I would echo their comments, but I think the key is preventing these fractures, as Dr. Savage was discussing. We often see patients in the emergency room or in our clinic that have a new vertebral fracture. A lot of our discussion is on the stability of that fracture, whether it needs surgery or bracing. But many of these fractures are fairly stable, and the most important treatment is getting them referred to a bone health specialist to minimize the chance of other fractures. The other patients we end up seeing several years later, if they haven't been treated and now come in with 4 or 5 fractures, and the patients you see walking around that are very hunched over or tilted way off to the side that now have a pretty severe deformity, and that would require a massive surgery to fix that and significant medication therapy to get the bone strong enough. And some, their bone are so bad that they just may never be a candidate to get them fixed. And a lot of those patients, if we look at their quality of life, it's about the same as double amputees, just because they have very poor function and are not able to walk around very well because of the pain and their alignment, where they may have more falls and get more fractures from that.
Yeah, and that's so frightening. I think that's part of the reason why we're here doing this, is to let people know that it doesn't have to be that way, that there are amazing new treatments that work, and there's really good prevention information that we can put out. So there are risk factors that you have for osteoporosis that you can control, and there are risk factors that are out of your control. And the things that you can control, diet, exercise, getting outdoors, healthy lifestyle, that we got to do those things, right? The things that we can't control that are a little bit out of our control, our genetic makeup, our proclivity, our likelihood of getting osteoporosis as dictated by our genetics. Taking medications for other conditions can affect your bones. We've talked about some of those things, Dr. Anderson, You and I were talking about that earlier. You can't control those things. So the good news is that there are good treatments that are available. And I'd like our doctors to talk to us a little bit about the hopefulness and the good news in the medications, because we do know that there's a reluctance to take medication for osteoporosis because, in the past, some of these medicines were not available and maybe didn't get a good rap out there. So can we talk about the good news in some of these medicines? Start with you, Dr. Elder.
Sure. So I think, especially if we look at some of the more widely used medications like the bisphosphonates, they have excellent data on preventing other fractures. They don't really build the bone up for us in preparation for surgery, but again, most importantly, they're at least maintaining your bone health and do have some improvement in it and hopefully prevent further fractures. But they're usually relatively inexpensive. They have different ways you can take it, whether it's just a pill every day or once a week, and then some IV formulations that are given every couple months or every year. Mm-hmm. So it's really not that onerous to take many of these medications.
Mm-hmm. One important thing to consider is that these medications will improve your bone strength, or what we call bone mineral density, in other words, how much calcium you have in your bones, by percentages. For instance, as Dr. Elder mentioned, bisphosphonates, a common drug, you're going to get a 4 to 5% improvement in your bone density or bones, but your bone strength, as examined by the ability to prevent fracture, goes up exponentially. That is, it's 60% improvement in resistance to fracture with only a 4 or 5% improvement in bone strength. So not only are these drugs adding more bone or more calcium into your bones, but they are also improving the structure of the bone. And it's kind of like bridge construction. You have all these girders going every which way to hold the bridge together. And if you take out one of those, the bridge will fall down. We saw that in Baltimore about 5 years ago. It happened in Seattle. A bridge fell down. It just one thing got knocked out, and our bones are like that. But what these drugs do is they repair the internal structure of the bone so that it is much greater to resist fracture. So a lot of patients are concerned, oh boy, I'm not getting a very good response, only 5% improvement, but that actually translates to a huge improvement in bone strength.
That's incredible. Yeah, that's incredible. Dr. Savage, do you?
I don't have much to add other than I agree with you. I think there is a lot of good news here. The reason why we're doing this, obviously, is I think awareness is probably the most important thing, right? And as a patient, you're always your own best advocate, right? So the more aware you are, I think the kind of the better you will be at kind of, making decisions about your health and talking to your healthcare providers. We haven't talked much about kind of when do you have to start worrying about getting evaluated for this. So I'll just kind of comment a little bit about that. In general, it's for women over the age of 65 and men over the age of 70. But if you have any risk factors, and one of the more common risk factors is if you're at long-term steroid use for some other medical diagnosis, that's a risk factor for osteoporosis. And there's a lot of other various risk factors that we're all aware of. So when we kind of talk to you about the potential need of being evaluated, you may be evaluated younger than those age groups. But.
Right. I don't know if we want to talk about this, but I'm going to toss this up and see what you all think. We've been talking about the fact that osteoporosis affects men and women, but some medications are not available for men. What do you do in that case?
Yeah, there are several very effective medications. Most of the studies are done in postmenopausal women because that's the target group for a majority of the patients with fractures. However, many of these medicines can work in men, and there's no reason they should not be used in men. The drug companies who make them have to go through a process through the FDA to get them approved for men. And all of the medications, with the exception of 2, are now approved for men. There's one drug that is a estrogen type drug that is used in perimenopausal women. In other words, women within 10 years of menopause. So you would not use an estrogen-type drug in a male, for sure. The other one is the most newest drug. It's called romosozumab. And we have plenty of medications that can really help you. And for instance, the programs to prevent secondary fractures that we just talked about are highly effective. They will reduce the chance of you getting another fracture by 60% to 80%. And not only that, they reduce the chance of you dying from that second fracture by 33%. So one of the consequences of adding more fractures is actually death. Even worse is many patients with second or third fractures end up losing their independence. And this is the most frightful thing to patients, is losing their independence where they can't live in their home anymore and they have to go to assisted living or even skilled nursing home forever. And I haven't met a patient yet who wants to do that.
Right. I'm so glad you brought those points up, Dr. Anderson. We're talking about osteoporosis and bone health because not only do problems with your bone health affect your quality of life, but it can actually affect your ability to be alive. And so I think people are often confused or unaware that fractures in your body, whether it's in your spine or other places in your body, can equate to earlier death, to an increased risk of mortality. So, again, we worry a lot about our heart health. We should. We need to take care of our heart health. We also need to take care of our bone health, because if you don't, you can die younger than you might have if you took better care. I'd like to have our panelists talk about that concept.
Let me comment about the risk of mortality with these fragility fractures in patients over 65. The 1-year mortality rate after a hip fracture in the United States is 25%. And this is true worldwide. Vertebral fractures are not quite as high. They're more like 15 to 20%. But if you add second and third fractures, then your mortality rate just geometrically increases. So that is one reason to try to prevent these fractures. I'm going to just go off a different topic. You can type in. Another advantage of secondary fracture prevention is that the treatment may actually accelerate the bone healing in the spine fractures and lead to faster resolution of pain.
Interesting.
So these new bone-building drugs look like the pain gets better faster with these medications, which is another reason to consider them.
Yeah, I think going back to the mortality risk of these fractures, when you get these fractures, you can start having a deformity. It can even affect things like your breathing, where you can have significant restriction of your breathing. And so even though you're not necessarily going to die from the fracture, they can cause a lot of other problems or make you sedentary, which really accelerates your risk of all sorts of medical problems.
The most important thing is obviously to try to prevent any of those things from ever happening.
Right. And in terms of talking about the mortality risk associated with fractures, there was a research study that came out in January of 2024, of just this year that we're in, that looked at vertebral fractures that were identified on CAT scans of patients who came to the hospital for other issues. So they maybe had stomach pain or something like that, and they were getting a CAT scan. And the radiologist who was looking at the abdominal problem also noticed vertebral fractures on that CAT scan. So the medical language for that is opportunistically identified vertebral fractures. And the mortality risk for those patients was increased by 50%. So the patients that came in had higher risk, double the rate of risk of death. And when they did corrections, so they corrected that statistically for gender and age, it was a 300% likelihood of early death associated with that. So the point there is that a lot of times people are walking around not knowing that they have these fractures, although there are signs. As Dr. Elder mentioned, you've lost an inch of height. It's probably a vertebral fracture, right? Could very well likely be. So if you have those fractures going on in your body and you don't know about them, it can result in a higher likelihood of dying. And so that's why we are talking so much about identify your bone health. Know what your bone health is. Know your bones and get treatment if you need it. Learn how to prevent fractures from happening.
Let me follow up about your height. If you look at generations and you can see grandma, mom, and then a teenage girl. Teenage girl's always 3 or 4 inches taller than the other and just progressively decreases as you get older. We can use the height loss as an indication to decide whether you need bone mineral intensity testing. The couple of rule of thumbs about that. If you have lost 1 inch recently of height, that has to be measured accurately in a doctor's office, or 2 inches of height from what you think is your baseline height when you're in your 20s. Those are indications to get your bone density test because you may well have osteoporosis and may well have osteoporotic fractures. So those are simple tests. They're low cost. They're not dangerous. But it means you do need to make sure they're measuring your height when you're getting a physical at your doctor's office and asking about, have I had a height change?
That's so interesting. We take our children in to the pediatrician to measure their height, and then we just assume we don't need to worry about height anymore. So if I'm in my 50s, why is my doctor measuring my height? Or why is my doctor not measuring my height, right? So
yeah. Well, good news there is if you've lost height, we can explain an increase in your it's called the BMI, which is how we're kind of looking at obesity, because the BMI is the ratio of your weight to your, basically your height, but it's really your body surface area. But so if your height decreases, your BMI goes up. So at least you can explain people my BMI is higher because I've lost height, not that I'm eating too much chocolate chip and cookies.
Yeah. And I think the other thing to highlight is that we normally think of fractures as being very painful. And a lot of these fractures people don't even know about. I've seen plenty of patients with 5 or 6 fractures in their spine that they had no idea until we got this imaging. They never had pain, never felt a pop, never had a bad fall. And so a lot of these are silent. And so looking at things like our change in height or getting a chest x-ray for something else and catching a fracture, those are clear indications that you need to examine your bone health and possibly get on treatment for it.
In fact, 2 out of 3 vertebral fractures are silent. In other words, patients didn't even know they had them. He oftentimes will say, I fell and I hurt my back and it was sore for a couple of days.
Yeah.
And that was 5 years ago. They don't even remember when.
Yeah.
But this is a common complaint, and it's very surprising that people would break their back without knowing it. But these are different kind of fractures than the ones you get in automobile accidents. Mm-hmm. These kind of are crush fractures that just kind of occur slowly over time rather than acute, bad traumatic injury.
We've talked about the development of science and evidence and how that relates to the practice of medicine. So many new treatment options for patients, so many different ways of looking at how to manage spine patients who have osteoporosis. I'm going to ask each one of our doctors to give us a closing statement. Dr. Elder.
Sure. Yeah, it's been a great discussion, and we've talked about a lot of things to watch out for, but I think the most important thing is that you're your biggest advocate. So if you see any of these things or if your family members experience everything, it's really critical that you talk with your physicians about investigating it further and ask them if you might need treatment.
Dr. Savage.
Yeah, I'll just echo with what Ben said. I think the most important thing is awareness. And so be your best advocate. Talk to your physicians about the potential need of being evaluated for this problem, particularly if you're in your 50s or 60s. And like we talked about, I think the recognition and potentially getting on medications for prevention is the most important thing.
Yeah, I think important message is know your bones and be your advocate, as the other doctors have said. Many physicians are not trained adequately in the management of the osteoporosis disease, and so they are reluctant to get you on treatments or diagnose the problem fully. So you have to be your advocate, certainly, especially if you're having spine surgery and if you've had a fracture.
I want to thank these spine surgeons, these experts, for joining us on the panel today. We call our surgeons healthcare heroes. They put the best of science into practice every day for their patients, and we are very grateful for them sharing their insight and their knowledge to give you hope that you can live your best life. Thank you for joining.